Good afternoon, my name is Ben Crouch and I'm going to be talking about environmental radiation monitoring in a large nuclear medicine and PET department following relocation to new premises. I am based at the Royal Adelaide Hospital, which was founded in 1841, so it predates nuclear medicine and in fact all medical imaging. The nuclear medicine department was founded in 1968 and we were based at the original site for more than 175 years. By 2017 we had outgrown the original site and the time had come to move to new premises. Here are some pictures of our brand new $2 billion hospital, which we moved into in September 2017. The hospital is located on the northwest corner of the Adelaide CBD. This is a layout of the department. As you can see, we're a large department. We have PET imaging, 2 PET cameras, 3 SPECT CT cameras. We also do bone densitometry and various non-imaging tests, including urea breath testing. When moving into new premises, it is useful to do a survey of the doses throughout the department. This is to make sure that the assumptions that went into the shielding design were justified and that nothing critical has been neglected. For our survey we use 30 standard OSL dosimeters. These are the same kind of dosimeters we use for our personal dosimetry. We did an initial 2-month survey, then changed the badges over and did another 4 months survey for a total of 6 months. Here is a map showing the distribution of the 30 or so dosimeters that we placed around the department. The emphasis here is on staff areas, so in particular control rooms, consoles, reception, the nurses' station. And here are the results of the initial 6-month survey. Some results have been omitted because they had a very negligible dose reading. The first observation here is that the highest doses, not surprisingly, come from the hot lab. We had 3 badges located through the hot lab and these 3 are our highest dose readings. We also saw quite a high dose in the patient toilet that is used by our PET patients. This dosimeter was adjacent to 2 patient toilets. We also found a relatively high dose in the waiting room, particularly in the initial 2-month period. But most interesting thing to come out of the survey was the higher than normal dose in the reporting room, and this turned out to be related to it sharing a wall with the anteroom, which is like the entryway to the hot lab, and we worked out that this most likely came from the PET doses that tended to be left in that area. Even though these PET doses are very heavily shielded with tungsten and so forth, there's still a significant dose rate coming from them because there's only so heavy you can make them and still have them, you'd be able to transport them and lift them out of the storage. So that was the main issue that we had identified from doing the survey initially. Since our initial survey, we've acquired some software that enables us to also monitor this area using the GM monitor you see pictured there on the right. So the particular reading from that monitor there is shown in the blue graph here. You can see a daily sort of variation where when the delivery first arrives at 8 o'clock, you see a spike, particularly when the doses are being taken out and measured, and after that a large portion of the dose is put into the automatic injector and taken out of the lab, but you have the afternoon dose still sitting there, which is decaying gradually, which explains the pattern you tend to see there. The corrective action that came out of this was to place our PET deliveries further from the adjacent wall to the reporting room to help cut down on the dose rate. So following on from our initial survey, there were some areas we decided that we wanted to continue monitoring, in particular the hot lab reporting room area and also the reception waiting area. The reception desk was being redesigned not just for radiation safety but also primarily to help with the workflow. So the new desk was finally installed in 2019. So these are the results from the ongoing monitoring that we did. You can see the areas listed there in the legend down the bottom. The highest dose is in the hot lab again, but there seems to have been a reduction in this particular hot lab dosimeter, which we think is related to a change in the shielding pots we use for our syringe doses. It coincides with the timing of that. Also, you can see the reception desk had one quite high reading. We've got two monitors here, one behind the shielded glass portion and one in front of the glass portion. You can see the amount is negligible behind the glass portion, but some non-zero readings from in front of the glass. You can also see in red that some of the doses in the reporting room have started to creep up again recently, so that's something that we're currently revisiting. So what were some of the lessons we learnt from the move for anyone who's in a similar position, getting ready to with this great big project, and making sure you don't get lost or forgotten? So one of the things that is really important is to have input early into the design of the department. You can't assume that you'll have adequate consultation, or if issues you flag will necessarily be followed up with you. Things can move very fast early on to the detriment later on, unfortunately. Particularly problematic also are these public-private partnership PPP arrangements. One of the unfortunate things about that is it cuts out the actual people who use the department in favour of external subcontractors who are doing the designing, and often these will be people without a nuclear medicine background, and so some of the things will be missed and need to be added later. Also, you get to a situation where the hospital's already been built and then there are these inflated penalties for any modifications. And so in terms of trying to apply ALARA, that becomes very difficult when you have these inflated penalties that are inherently unreasonable, and trying to come up with a reasonable compromise can be difficult. So, in conclusion, the area monitoring is valuable for pinpointing areas where radiation levels are higher than anticipated, and ongoing monitoring may be used to assess the effect of workload on department radiation levels, highlight areas for improvement, and assess whether changes to equipment and procedures are having the desired effect. Thank you.